And welcome to the Paramedic AF show. I'm Daniel.
And I'm Michelle.
Surprise. We haven't done that for a little bit, so
How about
throw you
this?
for a loop.
Listen, Lindas, it's time for another episode.
Goodness, it has been a week. I've lost track of time completely. I know we say that all the time because our weeks are just wild. But
They be wildin'.
yes.
You want to know what's partying? Not us.
Right.
You want to know what is partying? Our weeks.
So what's a weekend? I don't know what that is.
No.
Is that when we pick up more overtime?
No.
Goodness. All right. So a couple quick things to go over before we get into it. We are playing around with an idea for
Communication access.
yeah. So it solves a couple of problems. One is we love you guys, but we've also got a lot of traffic coming in the inbox from TikTok, and it's not that we don't want to interact with people more, but we can't. It takes a lot to do all the content creation for TikTok, for the podcast, and do some of the live, interaction. Like, it's one thing if you just share something funny, like, okay, cool, that's funny. But we have folks coming to us asking us like legitimate questions, or whether it's, questions about calls or
resources,
studying help, all of that. So we don't want to ignore that, but we can't keep up with that on our own.
Well, a notification sometimes drown.
Yeah.
Like in the activity log or notifications or whatever, they sometimes get drowned as well.
So there's two things. One, we do have the Discord server still going, and I need to fix the link because apparently the link is giving people some trouble. But we do have that as a resource because it's not just us on there, but there's a lot of other people there who have joined because they care about what we're doing, what kind of change we want to see in EMS, and making the field better as a whole. So that is there regardless.
Well, and we also kick off the troublemakers.
Yeah. We police that pretty heavily. I would say even almost more so than we do TikTok. If you're gonna come on and be a shithead and be, throwing ad hominem insults around all the time, no, you're getting fucking blocked. But people, we welcome disagreement. But specifically the Discord server, we try to police and keep it. Even if people aren't like as active all the time, when you do put feelers out there, do put questions out, people answer that actually care about it. So that's one. But something else we want to experiment with, and there's an app called Minnect. So it's Minnect. And basically what it is it's kind of like a pay-as-you-play version of like the Patreon subscription account. So for like Patreon, you would pay a monthly subscription to get special access to content, merchandise, all that stuff. We're not to that point yet. But what it is you can basically pay to get, you submit a question and select, if you want a text response, audio, or a full like custom video response. It is something that is paid for. So like you would have to pay, X amount for a text response, X amount for a video response. You can also pay for live phone calls. We can set those prices, but there are like bottom limits that we can't go below. So what we want to do, because running this podcast isn't cheap. We pay a monthly server fee. We had to pay for all the equipment, which we do, and that's fine. But we also want to upgrade the equipment, upgrade some other resources. So instead of just saying, oh, hey, here's our Venmo or here's our Cash App, give us money as you want to donate. It's more of, hey, if you basically donate, and in exchange, if you submit questions, if you want to, you want answers to specific things, either about your career, specifically about, medicine. Obviously, we want to keep it all EMS related. We're not doing life coaching.
Honestly, I would say it's more like tutoring. I mean, if we're being honest, the kind of like trade of like information.
Yeah, I mean, and it's not all necessarily going to be clinical though. So like if
I'm just talking about like the exchange though.
Yeah. It's or if you want something featured on a podcast, if you submit a topic, a remark, a question, whatever, we will bring it up on the show.
We do
So
that actively.
that's well, and that's our commitment with this is if you're willing to engage in this way, and throw a couple bucks our way for something, we will interact with it on the show, or depending on the context, we may throw it on TikTok if it's a short enough thing. But in some way, shape, or form, we will do that on your request.
This it's been around for a minute. Who made it
So
again? Who was the sponsor?
so it was originally created. It's been around for I want to say like a year and a half. And it was created by someone who I listen to their podcast regularly, Patrick Bet David.
That's right, PBD.
He is he has nothing to do with EMS healthcare, none of that. Well, I mean, he used to own the biggest life insurance company in the country, but that's not really related to this. But he created it he actually had the idea originally when he was interacting with his attorneys, because he'd have like a 15-minute call with his attorney and get billed for an hour, and he was like, "What the fuck, man? Like, why am I doing this?" So he created a platform for people to have access to experts or just influential people, and you can pay for the interaction, but you're only paying for what you're getting. Like, you're not paying obscene amounts of money and then getting a empty response. So
it's used a lot in the business field for feedback and stuff like that.
Business, politics, attorneys, that kind of stuff. I mean, there's actually some pretty famous people that are on there. So anyway, we're still investigating that. As far as I know, there's nothing stopping us from getting on there. I haven't run into anything that says we can't. So we'll probably do it where Michelle and I will have our own individual accounts, or we may do a joint one, or haven't worked out that detail yet. But that's kind of what we're going towards. So that way you can feel heard. There's still some value exchange. If you feel compelled to send some money our way, that's awesome. You're going to be guaranteed a response. Whereas, in the comments, yeah, we'll respond sometimes, but we might not. Like, if you want guaranteed interaction, we want to go that route for right now. It's not because, we're trying to be greedy or whatever. It's just our lives are crazy right now, and we may have additional responsibilities coming our way in the near future. So we want to bring that quality, but at a certain point, there's only so much we can do for free and still have lives. Well, still be able to enjoy our lives too.
Well, and keep the podcast free, because we have no intention of monetizing the podcast.
I'm okay with monetization if they're just going to give us money for doing stuff. But as far as running ads and stuff like that, we're not going to run any ads or anything that's not ours. So keep an eye out for that. More details to come on that. Michelle and I are separately. We're going to be starting 75 Hard coming up in
March.
Yeah. Well, I was trying to think a number of weeks. It's like within a week or so. Week and a half, maybe.
I think it's next Saturday. I think it's a week.
Okay. So yeah, a week from now. So, and we'll post about that on TikTok as we're going, and some progress. Basically, it's every day for 75 days. Each of us, we have to drink a gallon of water a day, read 10 pages of a self-improvement, nonfiction book every day. We have to do 2 workouts in a day. Each of them has to be 45 minutes long, minimum.
At least 2 it's either 2 or 3 hours apart.
And one of them has to be outside. And we will be following a diet. Again, there's no prescriptive diet from the program. It's just pick a diet.
It's basically just stick to some kind of eating habit.
Yeah. Take progress pictures every day. And that's really the key stuff. But if you miss a day, you have to start over.
So it could end up being a year-long thing.
We're going to aim for that not being the case.
Well, I'm just saying it in theory.
Right. And that happens to people sometimes. And there's more to the program, but that's kind of the initial challenge that we've wanted to do. We wanted to do it in January, but someone had to have surgery. So kind of fucked that up. But anyway, that's coming for your enjoyment. If you want to do it with us, awesome. We'll post more details about that as we go. So as far as call review today, it's actually my turn. And
normally turn. He was basically told, pick one.
Well, and because like we talked about before, it's been a long time since I've consistently run bad calls, so a lot of my memory is pretty foggy about it. But I had one. This was back.
I have not heard this story.
I think you've heard me talk about some parts of it, but I don't think you've heard the full story. This was back in 2020, I believe. Actually, it was late 2020. I was working for an agency that was had permanent backup for a county EMS agency. I had a third rider with me who was actually a seasoned medic that I'd worked with before. We get sent out to a shooting. Law enforcement cleared us to enter. We roll in. It was a drive-by shooting that allegedly nobody had any idea why it happened, but
Knowing that area, drugs. If we're being honest, drugs.
yeah.
Just saying.
So it was a 3-man crew, my EMT partner and my third rider. We had one of the county QRVs responded with us. We get there, and the county QRV had beat us. Basically, he said, dude's not doing so hot, he's pretty much about to fucking code. We're like, awesome. Let's get him out of here. So we got him, scooped him up, put him in the truck. We had a Lucas, thankfully, so we whipped that out. We had already called for a helicopter, so the helicopter was, on its way to the LZ.
En route.
En route.
It's en route.
We're not going to have that argument on here. Anyway, we'll put a feeler out, see what everybody does. That'll probably be our next TikTok videos. Which one do you say? But anyway, so he codes, but we start working him, and we kind of we keep getting him back and then keep losing him. Keep getting him back, keep losing him. So we make it to the LZ hoping that he, stays in ROSC long enough for us to get him in the air. The flight crew gets there, and the flight medic was my old captain from when I worked at that county. I was working for an assisting agency, but I used to work in that county. So he was the flight medic, and his partner was the flight nurse. I recognized her, but I don't remember her name. So they get in the back with us. We give them the lowdown on what's going on. This dude's not doing great. Several GSWs. I think it was at least 2 or 3, all to upper body. We ended up we couldn't stabilize him enough to fly, but the crew decided that they would ride in with us, and at this point we were just gonna go to
the closest facility
because he was just not. He was not going to make it if we did a 40-minute trip, because that would have been our closest trauma center. It was a good 45 minutes from right there.
Yeah.
So we rode nearest facility. They said, fuck it, we'll ride with you, and our helicopter will meet us there, and if we can get him stabilized there, and then we'll fly him. So we're like, okay, cool. So basically, I'm sitting in the captain's chair. The flight medic is standing in the little the stairwell to the outside door. My EMT partner, is the first spot on the bench, so I'm alternating ventilations with her. And then you have my paramedic third rider down on one side of the feet of the stretcher, and then the flight nurse on the other side. And then
who the fuck was driving?
The county QRV medic. He would have been completely fucking worthless back there. So
okay, I mean, fair.
I don't. Yeah, no, that was an executive decision on my part. You drive.
I mean, fair. Your EMT partner is competent, so
she for what we needed her to do, she was much more competent. Plus, she was about a third of his size, so it was already kind of crowded back there.
Jeez, that's a lot.
He makes me look small, so yeah, he's a big dude. So anyway, just this setup, the average medic would probably say, fuck no. Because you've got 3 paramedics, an EMT, and a flight nurse all in the back of this fucking truck. It was a lot. But, so we ended up, he got bilateral IOs with...
you couldn't get a line, or you just said fuck it?
We said fuck it. I mean,
fair.
all of that transpired in 10 minutes.
Oh, that's right. He was actively coding. Never mind.
Yeah. So he got bilateral IOs. He ended up getting bilateral decompressions. Cause I think we had one mid-axillary and one mid-clavicular. So he was actively draining blood with compressions.
That's a bad day.
Yes, it was. I intubated. Surprisingly, it was uneventful. And he was getting blood and plasma at the same time.
I'm assuming probably TXA and ANSEF.
I don't think we got that far.
Gotcha.
To be completely honest, because we were still pushing code meds too. We may have had an IV too. We had at least 2 IOs, maybe an IV as well. Because we were giving all the meds, all the things, all at once. Mm-hmm. Again, we couldn't keep Rosk, but we would keep periodically getting him back. I think we walked through the door with Rosk, but it didn't sustain.
I was saying, I'm assuming he ended up dying.
Oh yeah, he did.
Yeah.
He did. It was when we would, when he coded, it was usually PEA. but it was fast enough. Well, I mean, obviously, still had to work it. So anyway, super complex fucking patient. And like I've said before, I don't have all the numbers for you as far as vital signs and, you know, all of those kinds of nitty gritty details. The point from this story is every single person of every single cert level on that call behaved as a complete and utter professional. And there was zero headbutting. There was zero conflict, zero argument about any of it. I ran lead on the call. And, you know, since I was at the head of the stretcher, it was a little easier because, you know, I could manage the airway and still kind of keep dibs on everything else. My paramedic third rider was managing medications. The nurse was managing the blood. And I had the flight medic to just kind of consult and have as a backup in case I needed some help with the airway or with anything else. It was fucking flawless. And I really firmly believe that, yes, nobody likes having too many chiefs and not enough Indians, but we can actually run these calls with multiple advanced providers without it turning into a pissing match, without it turning into a butting heads over this and that. We got to do this thing. We have to do that thing. No, I think we should do this. No, we need to fucking do this. And fuck it, I'm just going to. There was none of that at all. Tensions, energy was way down.
Well, and like you said, I think it comes down to professionalism because, sure, in theory, every single person could have been paramedics, flight nurses, physicians, whatever. It's a matter of everybody was a leader in their own right. You know, your partner was, you know, knew that her job was respiratory.
To ventilate, yeah.
Yeah. But I mean, she was a leader in that sense and was able to take responsibility for her stuff. And if people can respect that, you know, you, technically the county medic, but you were first on scene for the call, not to overstep. You'd already, you know, put things into place and just fall in line. That's why we have standardization of training. So we can fall in line with that. So as long as you're not like royally fucking up, like everybody should be able to fall into the same pattern. So in theory, it shouldn't matter what the cert levels are.
Well, and also, it's very easy for people to get this complex of, well, because you called me for backup, ergo, I'm going to be in charge now.
Oh, hell no.
And
You're
there
there
was
for
none of
extra
that.
hands. Yeah.
There was none of that at all. Well, the paramedic who was first on scene could give two flying fucks whether he was lead or not.
Well, didn't want the chart.
Well, I mean, he still, in that service, they have to do their own charts regardless for QRVs. Even if they're not primary on the call, they still have to do their own chart. But no, he didn't have to do the full chart that we did.
That's what I mean.
But, you know, when the flight crew got there, and flight crews are typically pretty fucking good about this, at least around here. Like, they're usually pretty fucking good about, hey, you know, while we're still in the truck, this is your patient, you know, let's do a peaceful transfer of care here. But in that situation, you know, especially where I knew the flight medic, it's very easy for people to slip into, you know, older habits or whatnot. And none of that happened at all. Everybody stayed in their lane. If they had an opinion, they voiced it, but we did it in the proper way. Everybody communicated clearly. So it's not hard to do, but you have to be the one initiating that, because whoever's in charge is often the one who's leading the energy of the call. And that's the only time where I will start to take over if I'm backup is, hey, we're getting way too wrapped around the axle about shit. If you're all focused on the patient outcome and on the quality of the patient care, you don't have these fucking problems. Keep that focus, keep that emotional regulation, and be a goddamn professional. It's not hard. It's not rocket science. Be a professional.
Well, I would say, you know, have confidence in your training. Something that we've heard earlier too is you can't go into a call, even if it sounds like a shit show, you can't go into a call assuming it's going to be a shit show and fall to shit, or you're already setting the energy and your expectations. I mean, we've heard recently about, wasn't it a shooting or something, where there were a couple of providers heading to the call that were already getting worked up, that they couldn't handle it, that things were going to go south, you know, all this stuff. And it's like, well, if you go into it expecting that, you know, it's going to fall to shit and you can't handle it, if you assume you can't handle it, you're probably not going to be able to handle it if, you know, the call notes are actually, you know, what you find.
Yeah.
So don't go in with preconceived notion about the call. Do your job. Have confidence in the training you have. Have confidence that if you don't know something, say something. Don't
Yeah.
there's a certain
Yeah.
level of, don't fake it until you make it. But communication and emotional regulation.
Yeah. Well, and I kind of miss some of the old days. Ironically, at that same county that we were just talking about, we didn't have active 911 or anything like that. Literally, we had to write down the address and stuff that dispatch gave us, and just what the complaint was, and that's it. That's all we had walking into these calls. I kind of miss that sometimes because it was like it was like a game. Like you didn't know what you were walking into, except now it's still kind of like that. You're just told more sometimes incorrect information.
Well, I was about to say, honestly, I would say statistically the information is still incorrect, or at least like so far off. Oh, it's a diabetic emergency, but it's not.
Yeah, it's not.
It's not.
Yeah, but yeah, I mean, it's like today, the information you get, and it's not dispatch's fault.
Oh no! How many times we walked into a scene and the patient's like, "Oh yeah, I called in for chest pain to get you here faster," but that's not actually what it is. It's like, oh my
Yeah.
god.
Yeah.
So no, I don't. I mean, sometimes. I mean, dispatch is human just like we are. So I mean, there are genuine fuck ups and stuff like that. But no, I've been told actually entirely too much recently. The patient will be like, "Oh yeah, I called in this, but it's actually this," and I'm like, "Oh my god." Which
leads us to kind of some of our next topics.
right?
It's something that's come up a lot in
a lot.
well, and some of it we've already we've beat to death the whole narcotics topic.
Mm-hmm.
But the idea of gatekeeping with care, with access to emergency care, with gatekeeping leadership, all of this has kind of become a bigger topic, and I never thought about it that way.
Mm-hmm.
But there's a lot of ways in which, especially burned out providers, will use gatekeeping, I would say, as it's almost like it's a mechanism of power for them. Like they feel like there's a way that they can pull out their balls and be like, "Hey, look at me, I'm in charge, not you."
Well, something that I think we've also seen is the people that might have been grandfathered into a position when they see like the new and upcoming generation, if they know they may not be as intelligent or as experienced, or they're just insecure in general, they'll try and gatekeep almost like because they feel threatened, even though the person like incoming is not actually threatening.
Yeah.
It's an insecurity thing.
Well, and I think a very, very common way we see this is gatekeeping of medication.
Mhm.
And again, we've talked about narcotics, we beat that horse to death.
It's not even narcotics.
But it's simple stuff like being stingy with Zofran, being stingy with fluids. And I understand that there are a lot of gray areas between, hey, you know what? Sure, I could go down this treatment pathway with this patient, but they are legitimately stable. They're not to the point where it's a definitive intervention on their, for them that, depending on the nature of the system where you work at, can affect whether you ALS it or BLS it. But to withhold medications because you don't think the patient deserves it, or you just don't feel like doing it. Yeah, you're responsible for those medications, but they don't belong to you. They belong to your agency, and it is your responsibility to use them appropriately and freely based on clinical assessment and presentation. So just this whole like, oh, well, I don't feel like they're worthy of medications, or I guess I have to give stuff. Fuck no.
Well, and I know we've talked about overdoses, so we won't, go back and beat that horse as much either. I mean, that kind of plays into Zofran, because you've seen it where, they'll slam a fuck ton of Narcan and be like, they don't get Zofran, just let them vomit. It's like, fuck you.
Yeah.
But some stuff that we've seen recently is just Zofran in general with people vomiting. Yes, I understand it's not going to stop the act of vomiting. Finagrin would be better. But, like, let's fix the churning of the tummy. Let's give them some fluids. Something that astronomically appalled me is I was called out to an allergic reaction, and dude man had, like, obvious evidence of swelling in the arms. We're thinking, like, from an allergy to, like, grass, because he had been mowing. Maybe there was some kind of chemical he was using. I can't quite remember, but obvious signs of allergic reaction. The provider that was the ALS provider that was on scene with me, I was asking her question. Oh, do you want me to start a line for you? Do you want me to get, Benadryl, Zofran, what you want? No airway involvement, so it wasn't like anaphylaxis.
Yeah.
And she asked me to step out and talk to the other people on scene to like get the patient's information. Yeah, I mean he could talk, but she was like, give me some more information. Well, so I stepped out to talk to fire and the people. Next thing I hear click click. She fucking got out of the truck, got on the front seat, and BLS'd it. And I was like,
yeah.
And I saw them on a call later. I was like, did you give Benadryl? Oh no, my partner took it. Bitch, why? Why are we withholding Benadryl when there is obvious signs of allergic reaction?
Yeah.
I understand it's not anaphylaxis, but like, really?
Well, and like the diabetic I ran the other day, it was my last shift. It was a 20-year-old type 1 diabetic.
Yeah. Okay. Sorry.
Yeah.
It's coming back.
Yeah. He'd been, I think he was diagnosed with diabetes when like 8 years old. Dude was scrawny to begin with. I mean, his BMI was probably like, -2. And
that's the first.
And, of course we get there. We're called out for...
I think you said it was like a sick person because the complaint was vomiting, wasn't it?
Yeah, I can't remember if it was actually sick person or if it was coded as something else. But basically, sick person / abdominal pain. And get there, and dude's laying on the floor, left recumbent. And he's not like, hooting, hollering, causing a scene. But he's in obvious pain, distress. Complaining of severe abdominal pain, had been vomiting for in excess of 36 hours, was just not doing great, and we checked the sugar and it was 392. Mind you, this is an insulin-dependent diabetic who had taken his insulin already. It took like 12, it was either 12 or 20 units. I can't remember what family had said, but I mean, it's a pretty significant amount. Mm-hmm. And he had been hospitalized for blood sugar issues like 2 months prior. And he said when we walked in, I was like, he's like, I'm pretty sure I'm in DKA. And I was like, well, you're not in DKA, but you're not doing so hot either. His pressure was 136/78. Heart rate was the high 140s to 150s.
Oh, poor guy.
And he was not doing so hot. And so, I told him, I was like, dude, we're going to take care of you. We're going to get you in the truck. We got some medicine for you. I can give you some pain meds. I mean, he's in excruciating abdominal pain. Mm-hmm. And I felt bad because the medic who was on the truck, who was on the transport truck, looked like someone else that I know who's an EMT. So I just thought that I was the only paramedic on the scene, and I felt bad afterwards. I was like, sorry, like, I totally wouldn't have stepped on your toes.
But you didn't step on her toes.
Well, no, I'm just saying, like, my normal reaction to that would have been, sorry, like, I didn't mean to, because if there's another medic who's the transport medic, I, by default, yield to them unless there's some outstanding reason not to. Mm-hmm. And just be like, hey, cool, this is your show. Like, I'll say something if I need to, but otherwise, no, not really. So, it just depends on the patient.
She still should have stepped up and said, and identified herself.
I know. But I also acknowledge that I am not forceful. I'm not a forceful person, but
you're a big personality.
I'm a big personality. And when I'm in that situation, I'm running the show. Not that I'm not listening to other people, but I'm just very, like, cut and dry.
You don't have to defend yourself.
Well, no. Other people don't know me, though.
I mean,
so, like, I will just get in a flow of, okay, cool, this is what we're doing. I'm going to get stuff ready. You're good. You get them out. We'll work everything outside. Like, I get in a zone. Mm-hmm. And so, anyway, we get this guy out there, and he's actively vomiting. He's got nothing in his stomach. So it's just like, I mean, some of it's kind of green tinged. So, I mean, maybe he had some gallbladder issues, maybe. But, like, he's not having a great day. Mm-hmm. Couldn't keep any fluids down. So, got him in the truck. And I was like, dude, I got you. Got an IV established first time, which is hard for these kids that are brittle, mm-hmm. Lifelong diabetics. Mm-hmm. And I ended up giving him half a liter of fluid, which for his body composition was a fuck ton for a single bolus. He didn't want any pain medicine. He kind of freaked out when I mentioned that one of the ones I had was fentanyl, so I think that just kind of turned him off. I was like, dude, I got fentanyl, I got ketamine, like, I can make you feel so much better. He's like, no, I really don't want to do that. I was like, okay, well, let me know if you change your mind. Mm-hmm. Gave him some Zofran, bolused in all that fluid, and he was like, by the time like half the fluid was in, he's like, I
I
feel a
feel
lot better.
great. Yep.
He'd stopped dry heaving. His heart rate came down from, the high 140s to 150s to 116. Pressure came up some. I mean, he was relatively hypertensive, not like, oh my god, he's having a problem. His pressure came up to, like, 160 systolic.
Mm-hmm.
So it was up a little bit, but he's still not feeling great. And he felt so much better.
Mm-hmm.
And was as polite and sweet and pleasant as could be. Was not a difficult patient.
Mm-hmm.
All it took was some Zofran to give him some relief and some fluids, and he felt not 100% better, but he felt a good 75-80% better.
I guarantee you there are plenty of providers, because he was actively dry heaving
Mm-hmm.
and he was not in DKA, that they would have BLS that, unfortunately.
Yeah, and I mean, I'd have been fine if they wanted to, like, do the whole, like, sniff the alcohol prep pad trick, but
That
a
doesn't
heart
work
rate
for
that
everybody.
high,
Well,
heart rate
yeah,
that
heart
high,
rate,
fuck
yeah.
no, fuck
Mm-mm.
no, and the sugar. I mean, I'm sorry, I am kind of picky about that. Like, if your systolic is sustained over, like, if your systolic blood pressure is sustained over 220 and your blood sugar is abnormally high, sorry, I'm ALSing it. Like, whether you're truly symptomatic or not, for the most part, I'll ALS it.
I mean, same for the most part.
The pressures, I'll sometimes play a little dance depending on their history,
Mm-hmm.
both their chronic history and the history of present illness. But in general,
Mm-hmm.
if I have to give more than one justification for it, I'm gonna ALS it.
Mm-hmm.
I don't. I'll allow myself one. Hey, they're stressed out. They didn't take their meds.
Mm-hmm.
Something like that. But if I have more than one, no. So anyway, it's not hard to make someone's day better. And just because they're not dying doesn't mean that you shouldn't provide ALS level care.
Mm-hmm.
It's not your responsibility to be the arbiter of, their wellness, ultimately. I have a hard time with that. And no, I'm not like someone who overtreats everything. But have some fucking compassion.
Well, something that Daniel and I have talked about recently, and something that, for whatever reason, I don't know if it's just the age of providers coming in, going out, or what, but something that we've consistently seen / heard is with some, not all, this is a very generalized statement, but it seems like the people that tend to gatekeep meds are either the very young or the very old, like years of service providers.
Yeah.
Really couldn't speak to the new, because I would think that people would be like, yeah, let's do it all. But with some of the older providers, something that we consistently see / hear is, oh, back in my day, we didn't have all these cool protocols and my patient didn't die, so why do it now? Why change what ain't broke? And it's like, they may not have died with you, but did you really do justification and what is right by your patient by not being able to do shit back then? Because my answer to that is there's advancing protocols because of evidence-based medicine that is continuously advancing. I mean, now we have sepsis protocol and blood administration in the field. So like, okay, cool, you didn't do that, how many ever years ago, but obviously evidence-based medicine says you didn't help your patient, at least not as well as you could have.
Yeah.
So I feel like there's also kind of those two pathways as well with the gatekeeping of the medications. Like, oh, well, we didn't used to give Versed for seizures, so if they're not, meeting XYZ, what does it matter? It's like, that patient that just sees could seize again. Like,
Well, and I believe in a sanity check question of what would you want someone to do to your family member?
you know what? Apparently that doesn't matter though, because we've asked people that
Oh
on
my
TikTok.
god, there's some fucking dicks out there.
Yeah, we have asked people that, and a lot of people are like, I don't care if it was my kid. It's like, fuck you then. I'm glad you're not my family, because...
Well, and I think a lot of them are just keyboard warriors who are just trying to be difficult for the sake of being difficult. And because I see those people out there in the field running calls. You enjoy being difficult because I guess you think it's cool or something like that. I don't fucking know, but you're out there. You need to fucking quit.
Well, I feel like there are some people who like to wear the I'm a burned out, don't give a shit what you think about me as like a badge of honor. And it's like, I mean, there's a certain level of I don't care what people think about me that is healthy, but to the point that you're a piece of shit that doesn't treat your patients and don't care, like, oh my God, like,
yeah.
Leave.
Well, and it's those same people that like to gatekeep access to emergency care. They think that they're teaching them a lesson. Guess what? If you don't take them now, they're probably going to call back later.
I do want to hit because this is kind of related to a video that Daniel had posted about like how to ask or how to talk to patients, and I feel like what everybody is fucking focused on is the question of why did you call at 2 a.m. or what changed
Why
or
did you call
whatever.
911 now?
Yeah. We're not saying you can't ask that question because yes, that is usually one of the first questions that I ask is, okay, this has been going on for a week. What changed today? Or what changed at 2 o'clock in the morning for you to now call 911? Because it might be, oh, I've been nauseous, but now I have ripping abdominal pain that woke me up, even though, like, yes, you need to ask the question. It's, hey, hun, what, they tell you this, abdominal pain for 3 days. Okay, honey, so what changed, like, right now that made you decide to call 911 versus obviously not as inflammatory as cussing, but there are some people that walk on scene and are like, why did you call me at 2 o'clock in the morning for abdominal pain? Can't you just sleep it off? Like, we've heard people say that.
Yeah.
Like, you can't sleep. I'm sorry, I've had gastritis before. The answer is no. And sometimes that ripping abdominal pain comes out of nowhere. How many times have we fucking said it? It's not what you say, it's how you say it. And gatekeeping, and sure, there's a certain level of educating the public that we need to have.
Yes.
About, hey, the hospital is, this hospital in particular is overrun, on not diversion because they can't technically turn away patients.
Yeah.
But hey, with this kind of complaint, EMS is triaged. And I tell everybody because, there are some times where the hospital clears out and you may go straight to a room with a bullshit complaint. But let them know, hey, ambulances are triaged. If what I like to tell patients with kind of the vague complaints or whatever that are stable, all right, the ball is in your court. Here's all the cards on the table. You can go with me. The ambulance is going to get triaged all the same. So you may go to a room. You may end up in triage. You can go POV to the ER. This may or may not be appropriate depending on what the complaint is for urgent care. You may or may not be able to go to PCP. What do you want to do? We have to educate the patients, but like, even if it is complete bullshit, which I actually heard one come into the ER yesterday that literally grandma was afraid, like preemptively afraid of getting sick. So she wanted to go to the ER to get her blood work done. Yes, it's a PCP complaint. She didn't actually have like a sick or ill complaint or whatever. It's, her grandchild had come over sick or some shit. Literally no complaint. So I understand that's frustrating. But, like, it's also, at least as of right now, because of liability and whatever the fuck, it's not our responsibility to tell these patients, well, we're not taking you. We actually heard of a crew that had done this to a veteran earlier. Not, like, yesterday, but, like,
we don't know the details of the people involved. Just
oh yeah, we don't know we don't know anything. Just this seems to be something through the grapevine that we have been hearing consistently. Our crews, well, you're going to go to triage, so you might as well just not go right now and just wait it out. But guess what? These people end up calling back. It's not our responsibility to gatekeep people from getting medical care. Because, unfortunately, as awesome as urgent cares can be, there are plenty of complaints that they can't deal with. There's a lot of urgent cares now that can't take x-rays, can't take CTs, can't run blood work, can't get... Somebody said, actually yesterday, well, doctors' offices can give fluids and IV antibiotics.
A lot of them can't.
A lot of them can't. So there is a lot of stuff that, as bullshit as it sounds, there's a lot of stuff that does have to go to the ER.
Well, and what I have a problem with is people that walk into the call trying to get out of the call. Because what's going to happen is you're going to half-ass your assessment and start to push them towards a waiver. Try to make them feel like they're stupid. Try to make them feel like, it's not a big deal. And it may not be a big deal. But when you walk in with that predisposition, you're going to end up missing critical shit. And I'll give you a perfect example of it. I had went out for I think it came out as a chest pain call. And the way the guy described the symptoms was acid reflux. And, it was tied to when he ate, just the motion of the pain while he was talking about
spaghetti, right?
It was an acidic he had some spaghetti.
I know what you're talking about. Yeah, I think he had Italian food.
So, his vitals were fine. He didn't have any significant history. Like, he looked fine, and he didn't want to go. Well, what would a lot of crews that we know do? Oh, okay, cool. You don't want to go? That's fine. That's fine. You can sign right here. It's fine. We wouldn't force you to go. No, you don't have to go. And they back out so fucking hard.
Mm-hmm.
Well, magically, guess what? We talked this guy into letting us do a 12 lead real quick.
Mm-hmm.
Big fucking MI.
Mm-hmm.
Big one.
Like huge.
Yeah. Ray Charles could have called that shit. So, obviously, he got an emergent trip to the cath lab and got catheterized. And magically, he got better because of that procedure.
I think he was released like a day or two later. Like,
Yeah.
It was a very fast turnaround.
Yeah. So, guess what, people? Stop walking in with this attitude of... basically, it's like, well, nobody needs to call EMS. Is literally the attitude with which people are walking through the door. It's like, well, nobody actually needs to call EMS unless they're dying.
Well,
and I hear you, because I don't believe in calling EMS unless I'm actually dying.
Mm-hmm.
But I'm also a paramedic. So...
we're bad patients.
Yeah. But it is not your job to gatekeep and police their access to healthcare. You could believe it's totally fucking stupid, and it's okay to educate them, and it's okay. What I often have done for complaints that are not substantiated with any clinical backing, just told them, hey, if you want to go to the ER, that's fine. Here's what we would do. We would get you in the truck, we would monitor your vital signs, and that's really it. And we still get triaged at the ER the same way that you would if you went in your personal vehicle. So that is an option if you wanted to do that. But you also have the option of seeking care on your own, or call your PCP, or if you decide not to go right now, you can call us back. That's educating your patient.
Mm-hmm.
That's, now, obviously, if it's a situation where they need to go, and they're not wanting to, you need to, and I understand the protecting patient rights topic. I do. I'm a huge advocate of this. I will not try to find a reason to kidnap somebody. But if I believe that someone should go, I will do everything in my power to convince them they should. I will do everything. I will pull out the possible death card. I will pull out, the heart attack, stroke, whatever's relevant to the discussion.
I worked at one service. A guy who had a confirmed STEMI was refusing transport.
Mm-hmm.
So we called the fucking doctor. Like we called the hospital, asked to speak with an ED physician. And they talked to the dude. He fucking wavered. But man, that's one of those charts that you chart the fuck out of. But along with this, it's also gatekeeping education, because like so many times, let's take diabetics for example. That diabetics, especially if they're uncontrolled, non-compliant with medications. Yes, it's a laziness thing, but also in those appointments, 9 times out of 10, they're given a brochure and told to read it. Most people don't.
Yeah.
They need to be told something.
Or they read it and forget.
Or they're told, and there's such an influx of information and lifestyle changes that they have to make that they forget stuff. It's never going to hurt to re-educated people, gatekeeping information along with the emergency care. And like Daniel said, walking into a call already assuming, like, yes, on your way to a call based on dispatch information, like if I'm told, old man fell and is feeling dizzy. Okay, it could be something as simple as lost balance. It could be stroke. It could be, you should be thinking of differential diagnoses, but you shouldn't be thinking of reasons to get out of the call. Something with assessments, not rushing assessment, you also need to look at your pertinent negatives and your risk factors. Like, women, for example, who don't present cardiac things normally. If they're older, if they have diabetes, there's just a whole gatekeeping of information that needs to fucking stop. And look at the complications with COVID. A lot of people are having medical emergencies that are not presenting normally anymore, not just cardiac, not just cardiac in nature. Pneumonia, for example. Me, for example, I had clear lung sounds, but was septic with my entire lung full of pneumonia. And the only thing I'm normal was my vital signs. Clear lung sounds. So don't go in just assuming really anything. We shouldn't be gatekeeping emergency care or getting attitude preemptively.
Well, and I think that we need to talk about the relationship we have with our patients. And that relationship is very much a parallel of the relationship between a doctor and a patient. You would not want to go to your PCP with a concern. Say it was, just a cough. And it could be just weather change. Okay, cool. You wouldn't want to walk in to that PCP that you went out of your way to schedule an appointment with, that you drove up there to, and walked in the office, you wouldn't want them to walk in and be like, hey, how you doing? Why the fuck did you come here? Well, I have a cough. Okay, well, this isn't important. Get out of here.
Mm-hmm.
That's not appropriate. It is incumbent on you as a professional to do an investigation into your patient's complaint and their needs. And now you may find that it's not something that requires extensive intervention from you, but it is not in your job description to say you don't need to go see a doctor. It's not. What?
Just you saying that reminded me of when I went to my PCP with a dry cough, and that was my only complaint. And you and I sat down and looked at him like, dude, I know my lung sounds are clear. I know there's nothing the fuck wrong, but I'm telling you, listen to my medical history. I'm telling you this is pneumonia. And he was so taken aback. He's like,
okay.
He was like, okay, we'll take a chest x-ray. Literally like an hour later, he called me. He's like, so you have pneumonia for the second time in like a year and like, a couple days. He goes, so we're putting you on an antibiotic before you get septic again. Literally Daniel's so not kidding. Made a PCP appointment for a dry cough. That was it.
So, and I'm sorry, we're not physicians. And no. I hate the mentality of, well, we can't diagnose anything. Yeah, the fuck you can.
I can diagnose a STEMI and a fucking stroke, or at least stroke-like symptoms. I know you have those
At the bare minimum, you can say it's a TIA.
Yeah.
At the bare fucking minimum. It's a TIA that could actually be a CVA, but at the bare minimum, it's TIA. Or even like, hypoglycemia. I'm pretty sure I can diagnose you with hypoglycemia.
I think I know what hypertension or respiratory failure looks like.
So you fuckers that are just like, oh, we can't diagnose anything. Okay, well, you're also not a fucking doctor.
If you I would like to argue, if you have an AMLS certification, literally part of the concept of it is you have to come up with differential diagnoses. Even if you can't be like, oh, it's definitely this versus this. You still have to come up with a differential diagnosis list to take you down a treatment pathway. So if you are certified, yeah, you can. Even
if you don't have AMLS. That's the whole point of fucking paramedic school.
I just mean as a whole, you literally have a card that says you can. Yeah.
But I'm just like, I don't understand this. So if you're gonna go down that route, then okay, you're not a fucking doctor. You can't tell them for sure that something's not wrong. You can't diagnose them. You can't tell them what is wrong, but you can tell them something's not wrong if you're really gonna go that route.
Well, I think we've mentioned this before. You know how hospital ERs like put out, if you have this problem list, this is hospital appropriate. If you have this problem list, it's like urgent care appropriate. If we can expect laymen to basically diagnose themselves and decide, in theory, if they can go to a primary care versus urgent care versus ER, why can't we do some level of assessment and diagnosing as well?
It is incumbent on you to listen to your patients, because anybody who calls you with a complaint is a patient, and your relationship with them as a patient is parallel to the relationship between a doctor and a patient. So you are obligated to listen fully, to investigate, to educate, and to assist them in any way that you reasonably can. Now, should we just go out for, every person that says, oh, well, I need help getting from the toilet back to my wheelchair, and I need help getting, they call back separately for, well, I need help getting from my wheelchair onto the recliner. No, that's not a complaint. B, that's not what we're here for. And if you normally can do those things and you can't do them now, you need to go to the hospital and figure out what the fuck is going on.
Well, yeah, that's an acute change acute change in condition.
Yes, but this whole, but those are extreme examples that, yes, they do happen. You should still carry yourself with professionalism. But those are separate incidents that you can still use as a time to educate. And if the education involves law enforcement for legitimate abuse of 911, okay, cool. That's fine. It's not our job to police everybody that wants medical attention. It's not. That is not our job. Another form of gatekeeping that we have seen chronically, but I think especially the more we've delved into the topic of leadership, we've seen it more clearly, is the gatekeeping of leadership. And this belief that, there's some special Tao of knowledge, some special mojo that you have to have, and if you don't have it, it's like this exclusive club. Like, oh, once you're in leadership, you can't, it's like Fight Club. Once you're in leadership, you can't talk about leadership. Like, I have a huge problem with that. I have a huge problem with whether intentionally or unintentionally gatekeeping leadership education. And I think fire department the fire service in general does a better job at this. They are much more structured with access to leadership training.
Mm-hmm.
But
I mean, they literally have like a series of classes
Mhm.
that people can just go to.
yeah.
Now, taking the leadership classes is how they determine if somebody qualifies for like a promotion,
Mhm.
but they don't gatekeep it.
Now, but I would say it's not just whether you've taken the class. There should be actual, like, personal mentorship and investment in people regardless. And I really think it should be a culture shift for us, because you should be educating everybody on leadership, because one, you will actually utilize leadership in just about every aspect of this job.
Mhm.
Two, you may prepare people for leadership that you didn't expect to.
Mhm.
But ultimately, you want to have a good pool of people to draw from. And if you're not actively investing in qualities of leadership and enforcing some level of qualities of leadership across the board on everybody, then it's going to be a lot harder to get those good people who actually have the potential to be quality leaders, because they haven't been given the opportunity to show it.
Well, and I feel like it's kind of like with medicine, see one, do one, teach one. Once you become a leader, if we have a mentorship and we have like an open dialogue of stuff, you can make yourself a better leader by getting someone else's point of view. I mean, ideally, and I mean, this goes for paramedics, EMTs, I won't say drivers, but like literally people driving, as we mentor each other, I would like, let's say I'm a leader, for example, in whatever capacity, an FTO, whatever. I would like to be able to train my people and give them enough confidence that they know how to do the job, almost like, working yourself out of a job.
Mm-hmm.
Like
That's
training,
literally exactly how it's supposed to be.
I mean, that's how it's supposed to be, because each generation, like especially as EMS advances, if medicine is advancing, why are we not improving like our connection with our people and people being able to lead themselves? Like Daniel's EMT partner on that call that he talked about at the beginning of this. Like she was a leader in of itself for her job. She took full responsibility for that, was able to pass up information if Daniel and her could have a lateral conversation about, hey, we need to fix this, or hey, we need to add this, being able to independently do their stuff. And something I've seen some places more than others, and obviously you're going to have your great places, your mediocre places, and your shitty places that you work. But something I've consistently seen, especially depending on the school of thought with leadership, is you have people in leadership that got their position, whether they were grandfathered in, whether they were the only one at the time that was interested in the position or whatever. It historically does not have a good reputation as being a leader. Well, now it's time for the new generation to start coming up. And I've also seen this with like hiring orientations, assessment centers. Depending on where you work, it's called something different, and their processes are different. But how often do we talk about, you have the professional references and then you have like the personal ones that, like, well, I know this person that worked at that place that knows this person. I'm going to see if there's any dirt. And like, sure, there's a certain level of that matters. Like if you have a sexual harasser, moving around, blah, 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 reputation does follow. But when it comes to like leadership gatekeeping or even job gatekeeping, like if somebody's up for a promotion, even if it's not like a big, like, over the whole shift promotion, you have these leaders or, whatever in a certain position that whether it's in security, they know they're bad at the job. It could be a whole lot of things that turn around and try and gatekeep, and it's like, well, I'm going to find the dirt on this person, or I don't like this person. They're not going to be a good fit.
Yeah.
It's like, but you don't know how they would be, and because of your insecurity, you're going to try and gatekeep somebody that might basically work you out of a job. Like that's not okay. We should, even in leadership, we should be wanting to improve ourselves.
And I think that we often get locked into this mentality of, oh, well, EMS is different. Like there's some secret sauce about EMS that it excludes us from the normal conversation about leadership, and that is just patently false.
Mm-hmm.
Because there are so many resources out there on the topic of leadership from so many different disciplines, and there is so much of leadership that literally has nothing to do with medicine. Yes, there are some tactical applications that apply to EMS and fire and police specifically, but ultimately, learning how to be an effective leader is something that we don't educate on enough. And often it's like a small amount of education is worse than none at all.
So funny
And
that you say that. I have that opinion about certain certifications.
but like we got onto the topic of talking about the different kinds of leadership. There's like 8 different leadership archetypes.
Like
And
the primary archetypes.
yeah, like, transactional leader, coaching leader, inspirational, democratic, autocratic. Being a leader isn't any one thing. It's not like, like the servant leader. Well, that's a archetype of leader. There's times where you have to behave that way. I think the archetype should be referred to as a set of behaviors, not an exclusive model.
But I think where we get into the problem is you have people, whether it's insecurity, inexperience, they're too old for their position and they're, set in their ways. That truly, I mean, how many times have we talked about certain people that are only autocratic and it's their way or the fucking highway, even if they're dead ass wrong. And I think this goes back to, for example, leadership is ever changing depending on situation, depending on personalities. It's kind of like being a parent to children. Daniel and I think have actually brought that up on the podcast before. But let's take personality traits, for example. Everybody, even if you don't know it by heart, everybody is aware of zodiac, like preconceived notions, correct? What
Libras for the win.
What is the one that like historically is like just labeled as a bitch or labeled as
Aries?
So you have Aries, and I think Cancer was the other one. But if you're an Aries or a Cancer, do you truly identify with every single like listed personality trait, or do you change? I'm a Capricorn. There are certain aspects of Capricorn where I'm like, oh my god, that's me, and there's other ones that I'm like, no, like never. And then there's others is like, maybe. So I mean, unless you're gonna say that your zodiac is truly your entire personality 100% of the time, you can't identify and stick with only one leadership archetype. And it was our January book of the month last year, Extreme Ownership. So we talked about it. We read the book, all the things, and I took it to heart, as I think everybody should. But again, that was only a little bit of the puzzle, and apparently the authors got feedback that people took it to heart and held it as completely true, that with extreme ownership, you take ownership of everyone's mistakes, it is your responsibility, all the things. So they came out with a second book called Dichotomy of Leadership, and they dive deeper into it that discusses literally there's a time and a place to be a leader, and there's a time and a place to be a follower, and the dichotomy of all the different decisions is being able to flow between things as situation is necessary. That if you stick to one hard set of rules or, one habit, if you gatekeep the information, I don't think they use the word gatekeep, but they use something else. You have to have the dichotomy of changing with the times.
Because you're gonna have people that need different things, just like we've talked about with parenting. Different children need different things. They need you to be a different kind of parent at different times in their development. So it's important to teach people the nuance of leadership, and that there's not always a one size fits all stylistic approach to it, because it also requires you to be you and play off of your strengths and weaknesses and your personality, your energy. There's some people who they have no problem when they have to be autocratic in a situation to say, hey, fuck you. This is what we're going to do. Period. The end. Get to it. There's some people where that comes naturally to them versus, whereas they may struggle with a more democratic behavior. But then you have the complete opposite. You have some people who are like gung-ho, democratic all the way, I own that shit, and they struggle with the more autocratic behaviors So you need to learn your strengths and weaknesses in that context.
I think an example that we have given is I was actually on paramedic ride time. We were called out to chest pain that turned cardiac arrest, whatever. We're working it, get to the point where it's transport because the person meets criteria for transport. Well, we're like 20, 30 minutes into this, loading up into the truck, and the supervisor finally shows up, which, I mean, I have no hate on her about that. I mean, it is what it is. But she finally shows up 30 minutes into the code, has no fucking idea what we've done. She gets in the truck, she goes, "Okay, we're doing this." And she immediately bulldozes over. And at that point, we already have 3 paramedics on scene. She's the 4th one. She's the last one on scene. And she's like basically trying to start us from the beginning. And it's like, I understand you're a supervisor, but at this time you're an additional set of hands. There is a time to be a follower. Having the, whatever your title is, for ship supervisor, QRV, whatever it is at your place of employment, does not automatically mean as soon as you get on scene you take over lead on the call unless somebody's like royally fucking up. And she did that. It's literally, her mindset was, well, I'm the supervisor. I made it on scene. I have more experience. Fuck you. We're doing this. And it's like, dude, we've already done that like 30 minutes ago. And then it turns into a whole dick measuring thing. It's like, there's a time and a place to be a leader, time and place to be a follower. You have to, go as the pendulum swings.
You have to respond to your people and to the situations. I think another reason that there's kind of some gatekeeping on leadership overall is people don't want to be called out as bad leaders. Because I guarantee you, if you start reading Dichotomy of Leadership, anything by Simon Sinek on leadership, you're going to start seeing negative behaviors. And obviously nobody's perfect. No leader is above reproach. You have to be, but this is where the leaders need to not only be held accountable by people above them, but also by the people below them. You do have you are required to be accountable to the people that work for you because they're following you, they're following your leadership, and you are responsible to be honest and to be fair. And so you are accountable to those people as well.
Well, and even if you're a good leader, there's still a certain level of needing to continue to research and better yourself. And I mean, how much more have we learned about the brain and psychology? I mean, there's ever changing, inner child work that affects, adulthood. There's more and more research now that you have to keep up with bettering yourself, bettering the service. No one is ever going to reach perfection. There's always something you can change. And like Daniel said, we're all human. Even leaders they talk about it in Extreme Ownership and Dichotomy of Leadership. Anybody can make a mistake. It's about extreme ownership, owning the mistake, vowing to do better, learning from it, learning what you can do to do better. And it's fine if, it's kind of like an EMT calling out a paramedic. Shit happens. Just because a subordinate, not, derogatory, but lead up, lead down. Even if a subordinate calls out leadership, like, admit you're wrong. If necessary, apologize, make, some kind of action plan to better yourself and keep on keeping on.
It's not rocket science. It just requires you to actually care and actually be a fair individual, a fair leader. Well, and look at the long-term investment in your people.
I think part of the problem too is, having pride and letting your ego get in the way, which seems to be, well, I want to say a generational thing, but it's just something it's something consistently that some people naturally have, and then some people are taught. There are some services, even though, back in the day they were the shit, and they're no longer the shit, but they still, for whatever reason, their culture teaches you are the shit.
It took them 25 years to take down the acknowledgement of their System of the Year award.
That's unfortunate.
Yeah, anyway.
But sometimes it comes, naturally, unhealthy naturally, and sometimes it's cultural and it's taught, but it's good to be proud of yourself when you've gotten an award, an achievement, whatever. But don't let it fluff your ego to the point that you think you're infallible. Like, have pride, don't be prideful, and don't let your ego get in the way. And that can go for anyone in leadership. I'm a leader, I'm in charge, do what it's almost like the whole like sub-dom thing. I'm going to dominate that. You laugh.
Oh no, I'm laughing because it's true.
Yeah. There's a time and a place.
Yeah. So, stop gatekeeping. Do your job. Treat your patients appropriately. Invest in your people, whether you're actually a member of leadership or you're just a paramedic on the street who has EMTs that look up to them. Mm-hmm. Invest in your people actively. Give a damn. Give a damn. That's it. You don't have to be Mr. Superhero Gung-Ho. Yeah, I'm out here making a difference and saving lives. Just give a damn about doing your job properly and being a fucking professional.
Well, and piggybacking off that, I want to say, invest in yourself. There's really no other. I was trying to think if there was a better way to say it, because even if, and we've actually had a couple people tell us this. Now that we're trying to get this information out, there's been a few people that are like, "Hey, I acknowledge I've been really shitty to my EMTs. I've had a bad attitude. I let my overstimulation or what, my bad night or whatever it may be." Run my call, run my shift, run, my personality. Invest in yourself. It is literally never too late. We should be learning and exercising our brains until we fucking die. And even then, play music or a podcast or something for me as I'm dying.
Listen to the Paramedic AF show. That'll help you. Getting better.
Yes, fair. And we don't think we're smarter than everybody else. Share resources with us. I mean, shit. You want us to research a topic, or if you tell us about a new book, we'll go look it up. Our wanted book list is
huge.
It's unbelievably long.
It's growing.
It's unbelievably long.
Yeah. Our to read that we own list continues to grow as well.
Yeah, not even our ownership books, but the ones we want to buy and own. But yeah. I would say the biggest thing is if we're investing in ourselves, it's gonna spread. I mean, it's gonna spread to your partners, to your family, to your children, to if you share resources with upper management, maybe you know of a book that they don't know. Dichotomy of Leadership. I'm not gonna lie, that book hurt my feelings because I was like, oh, I took the extreme ownership to the extreme.
I've heard that story a few times before from people. Anyway, don't suck as a person. Treat your patients well. Treat your partners well. Treat yourself well. And if you learned something today, good. That's awesome. Tell your friends about it. If you were offended, good. Go ahead and tell them about it too. And we'll see you guys next time. Bye-bye.